Hi everyone. So we are going to continue the discussion by talking about the rectus sheath hematoma. And this condition typically results from bleeding due to um, trauma or injury to the deep inferior epigastric artery, um, where it insects into the rectus abdominis muscle. Um, Dr. Abayinde must have talked about the arcuate line in the enterology discussion. So the rectus abdominis muscle is covered by an aponeurosis that we call the rectus sheath, right? And it's kind of we can just picture the rectus abdominis muscle as a muscle that is enveloped, by the rectus sheath. So it covers it like from anterior to posterior. But at the posterior end, there's a part of the posterior end that doesn't have the rectus sheath covering. So that is where you call the arcuate line. So let me show us a picture that shows this. So let's look at the arcuate line, the arcuate line of the abdomen, so that we can appreciate this anatomic landmark. Okay. So um yeah, so this is a very good picture. So we can see the rectus abdominis muscle. We can see this is the anterior view and this is the posterior view, right? So we can see the posterior wall of the rectus sheath, you know, covering the rectus abdominis muscle until this part. So this is where the posterior sheath stops. So below, you don't have any covering. So this is a point where the inferior epigastric, the deep inferior epigastric arteries penetrate into the rectus abdominis muscle at the arcuate line, and that is where you have the posterior border of that's where you have the inferior border, not posterior, where you have the inferior border of the posterior rectus sheath. So that is the inferior most border of the posterior rectus sheath, and that is also the point where the inferior epigastric artery penetrates into the rectus abdominis muscle, right? So it means that that area is not well reinforced. It means that the inferior epigastric artery at that area can easily tear off because of that lack of the posterior reinforcement. So that's when and that is exactly where the rectus sheath hematoma forms. That's why it is inferior in its location. So below the arcuate line, the posterior aspect of the rectus abdominis muscle is no longer supported by the posterior rectus sheath. So it predisposes the inferior epigastric arteries at that point to like sharing forces, and they can, get torn, leading to bleeding into the rectus abdominis muscle, right? And they are kind of enclosed within the sheath, forming the rectus sheath hematoma. So that is very, very clear. So for this reason, most rectus sheath hematoma are located in the inferior abdomen. So that makes sense because the arcuate line is located in the inferior abdomen, and that is where the inferior epigastric artery penetrates into the rectus abdominis muscle. That is where you have the inferiormost border of the posterior rectus sheath. So that means that vessels at that point, they are not having any postural support, so they can easily shear off, leading to bleeding. So individuals with rectus sheath hematoma, how would they present? So what we are just discussing previously, just more like the anatomic landmarks. What we really need is to identify the way those patients will present. And one thing they usually present with is what? Acute onset abdominal pain. They are going to complain of acute onset abdominal pain. You are going to have a palpable abdominal mass, right? At the same time, they might tell you they are feeling pain at the back or pain in their leg. So they are most likely having a referred pain because you can have the hematoma compression on the thoracic nerves and the lumbar nerves, right? The thoracic nerve supplying the back, the lumbar nerve supplying the lower extremity. So, you know, um, so that's why they have those referred pain. And there are some certain signs you can elicit on your clinical examination to confirm your diagnosis, right? And this includes the Canet sign, and the Fortagio sign, the Canet sign and the Fortagio sign. So basically what you are just trying to do is just to delineate the source of that pain and the hematoma. If it's actually coming from the abdominal cavity or it's coming from the abdominal wall. Because if this is a situation of an individual with rectus sheath hematoma, the source is definitely from the abdominal wall. So we have to be sure. We have to get positive sign from the Canet test, positive sign from the Fortagio test. So for for the for the Canet test, what you are just trying to do is that you are trying to tense the rectus abdominis muscle, and with tensing of the rectus abdominis muscle, you expect the pain to get worsened, right? That's what you do. So you tell the patient to sit supine, they stay supine, then later they sit up. So when the patient is initially supine and they sit up, it kind of contracts the rectus abdominis muscle, and you notice that the point of maximum tenderness is either unchanged or it's increased, right? It doesn't reduce. It does not reduce. So that's about the Canet side. The maximum point of tenderness that you are able to identify during your examination remains unchanged as the patient changes from a supine position to sitting upright, causing contraction of this rectus abdominis muscle. It doesn't change or it increases, but it never reduces. If it reduces, that means you are saying the source is actually from the abdominal cavity. So that's the Fortagio sign. And for the that's the Canet sign rather. Why for the Fortagio, what you are just doing is that you are trying to evaluate if there is a change in um the 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 position of the mass, if it moves across the midline or it kind of changes in position with the movement. So what you are trying to do is you are trying to contract the rectus abdominis muscle, and you are trying to see if the mass moves, across the midline. If it's from the rectus sheath, if it's within the rectus abdominis muscle, it is a fixed position. It doesn't move, right? Even with contraction of the rectus abdominis muscle. So what you do is that you can tell the patient to also stay supine. You can tell them to raise their heads, right? Like raise their heads. That will tense the rectus abdominis muscle. Or you can tell them to lift their legs, right? So they stay supine, they lift their legs, or they, raise their head. Those two maneuvers contract the rectus abdominis muscle, and you notice that the mass stays in the middle. It does not cross the midline. It stays, in a certain position. It will not cross the midline, and it will not move, with movement of the extremities of movement of the head. So that's the Fortagio. Fortagio sign does not further moves, you know. And how do you confirm your diagnosis? By doing your imaging. You have to do your CT scan. You do your CT scan to confirm the presence of the hematoma. CT scan is what you do because these patients are having bleeding. You actually need to do some hematologic workup. You need to check the full blood count, you know, the blood level. If there's a need for transfusion, you immediately transfuse, particularly when you have the hemoglobin count to be less than 7 grams per DL. You definitely need to transfuse those patients. Sometimes you might need to just give fluids, Hartmann solution, and they're in good shape. Then you need to evacuate that hematoma, right? So you do your CT guided surgical evacuation of the hematoma. And if you can identify the bleeding inferior epigastric vessels, you can do a surgical ligation of those vessels. And you have to leave a suction, to drain up all the blood that might tend to accumulate within that compartment after the surgery. So that is about the about the rectal sheath hematoma. So the next is the bladder injury. So first of all, we have to know that we have two classes of bladder injury. We have the intraperitoneal and the extraperitoneal. Intraperitoneal, I know we have discussed this, in our step one, we know this very well. Intraperitoneal injury just means we are having injury to the part of the bladder that is covered by the peritoneum. And the part of the bladder that is covered by the peritoneum is the dome of the bladder, which is the superior portion of the bladder, right? Just like we have in our step one here. So okay, yeah. So this is the dome of the bladder covered by the peritoneum. So that is the intraperitoneal injury. If you have injury to um, the 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 neck, of the bladder or the trigon of the bladder, that area is not covered by the peritoneum. So that is extraperitoneal injury, right? Both of them, you need to be able to identify them. You need to be able to distinguish them because they have different approach, in terms of the treatment, right? Um, so they have different approach in terms of the treatment modality. So one thing I must first mention is that an individual with bladder injury, they usually present with some clinical signs and symptoms. And first of all, you are going to get the history that the patient is having hematuria. So the patient might, have hematuria. You can you can get history of the patient complaining of suprapubic pain. So you can also elicit suprapubic tenderness, right? Hematuria, suprapubic pain or tenderness. Of course, they'll have difficulty voiding, right? Those are the three major findings in an individual bladder injury. So you need to act for that to delineate between the two types, right? So for the intraperitoneal one, which is the one that affects the dome of the bladder, it usually occur in people involved in motor vehicle accident that are using a seatbelt. So if they are using a seatbelt and the bladder is full, so a sudden deceleration, from the accident can actually compress the bladder. The seatbelt can compress on the bladder, and if the intravesical pressure increases, it can cause a rupture of the dome of the bladder. When the dome of the bladder ruptures, there's extravasation of urine into the peritoneum because don't forget the dome of the bladder is covered by the peritoneum. So that means that urine can easily escape into the peritoneum. Urine is going to be absorbed by the peritoneum, and from there, urine content will get into the blood, right? So the patient is going to present with elevated blood urea nitrogen levels, right? And you notice that there's going to be low urine output despite aggressive resuscitation rehydration. So, and again, because of the fact that the urine is entering into the peritoneum, they are going to have signs and symptoms of chemical peritonitis. So, which include like diffuse abdominal pain, guarding sensation, rebound tenderness, and rigidity. So, you definitely need to surgically treat a patient with peritonitis. So, that's why intraperitoneal bladder injury involves surgical correction. Then, for the extraperitoneal bladder injury, the injury is most likely confined to the bladder neck or the trigo. So what happens is that you have like a pelvic injury. There's a pelvic injury, right? Maybe there's a fracture of the pelvic bone, if pubic bone, punctures, release some speckles that punctures into the anterior neck of the bladder or the trigon of the bladder, and immediately you just have urine tripping out from this part. And when urine starts tripping out from this part, it's going to extravasate into this region. This is the pubic bone. This is the back of the pubic bone. So that means that we are going to have a retro, that is the back pubic collection. So you are going to have a lot of urine filling up this space. Urine is going to start pulling up within the retropubic space, but they are not going to enter into the peritoneum. They are not going to cause elevation of blood urea nitrogen level. We are just going to have, you know, urine pulling up within the retropubic space. So that is all. What you just need to do is just to put in a suprapubic catheter so that you can drain the urine, from the bladder before it even moves downward to extravasate. That is just what you need to do to take care of that patient. If you want to investigate them, you might need to do a retrograde cysto uretrography. So to look at, the extravasation of the contrast from the bladder. For people with urethral injury, um, just like the bladder, they have um, um, just like the bladder too, they have the same um, category, just posterior and anterior. So, um, is there anything I'm missing? Okay, yeah. So the urethral injury, you know, first of all, is very common in males, right? Yeah. So the urethral injury is much more common in males because females have shorter urethra, right? So males have longer urethra. You have two classes of urethral injury, just like in the bladder. You have the anterior and posterior. So this is not categorized based on peritoneal covering, but just based on the position, anterior and the posterior. One thing I want to mention is that most of the time, don't pick passage of urethra catheter for treatment of urethral injury. You don't want to pass a urethral catheter because sometimes you don't even know the extent of the injury. It might be a partial tear, a partial rupture. By the time you are passing your urethra, you can make it complete and you can exacerbate that genitourinary injury. So most of the time for urethral injury, you want to avoid passing, a Foley's catheter through that urethra. Please, you have to pay attention to that. So we have to go back to our step one to look at the classification of the urethra. So we know that the urethra has four major parts, right? The prostatic urethra here, the membranous here. This is the bulb of the penis. So the urethra that starts from the bulb is called the bulbar urethra, then down to the penile or the spongy urethra. So the spongy, the bulbar urethra, the membranous urethra, then the prostatic urethra that runs to the prostate. So the two that are categorized as the posterior are the ones that are backwards, and that's the prostatic and the membranous here. While the bulbar and the spongy makes up the anterior. They have different mechanisms of injury. Um, the posterior urethral injury occurs when an individual, experiences a pelvic fracture, right? So, and the most liable portion of the urethra that succumbs to this pelvic trauma is what? The bulbo-membranous junction. So, somewhere at this point, this is the weakest part. So, this urethra here can get torn, and immediately you have urine extravasating into the retropubic space. And what happens after you have retropubic space urine extravasation? The urine is going to be pulling up at that point and is going to start elevating the prostate and the bladder. And by the time you are doing your DRE, you can feel for a high riding prostate. So that's a sign of a posterior urethral injury. So high riding prostate. Almost all the cases of urethral injury will cause blood at the meatus of the penis. So you are going to see blood here, right? You can feel for high riding, prostate. The patient can tell you they have difficulty voiding, right? They can tell you they have um you can get the finding of microscopic hematuria. Most of the time they might not have gross hematuria because gross hematuria is very common with bladder injury and renal injury, but they might have microscopic hematuria. Yeah, they can have high riding prostate, they can have scrotal hematoma, they can have a perineal hematoma, a perineal pain, they can have blood at the meatus, they can have difficulty in voiding. So we are going to take them one by one. And so the most classic finding for posterior urethral injury is what? Is the tear very close to the prostate, right? And this causes urine pooling at the retropubic space, elevating the prostate and the bladder, causing a high riding prostate. You will not find high riding prostate in an individual that has an anterior urethral injury. That's the first thing. There is no high riding prostate in an individual with anterior urethral injury. So what they are going to have is that they would have scrotal hematoma because the tear is happening here, and you have blood, urine extravasating into the scrotum, right? The urine can also find its way into the superficial perineal space if you have a concomitant tear or the rupture of the bulk fascia, right? So that is that about the anterior. They complain of scrotal hematoma. You can find urine, within the superficial perineal space. They can have perineal pain, perineal hematoma generally. So let us go back to our step 2 first stage so that we don't miss out any points, right? So first thing is investigating an individual with urethral injury. That's the first point that is mentioned here. You want to ensure that you are not inserting a urethral catheter until you have done your retrograde uretrography. You have done your retrograde uretrography to rule out injury to the urethra. So once there's injury to the urethra, you want to hold on to passing a Foley's catheter to the urethra at that point. And what are the clinical presentation of an individual with urethral injury? You are going to get history of blood at the meatus. You are going to even see it yourself, right? For situations of posterior urethral injury, they can have a high riding prostate, right? Both of them can have history of difficulty urinating, right? For the posterior urethral injury, they have pelvic fractures, right? Pelvic fractures. The anterior urethral injury is actually with perineal trauma, like falling astride, right? Landing on an object with their perineum. So when you land on your perineum, like an object is, you are hitting your perineum with an object. That's like falling astride. So that can cause injury to the anterior urethra. But with a pelvic injury, it's more of the posterior urethra. So we have defined the anterior urethra to um, be the penile and the bulbar urethra, right? And the injury to the anterior urethra is very common in individual penetrating trauma to the penis, penile fracture from any cause, or straddle injury. Straddle injury is very common. So watch out for that in the question step. Falling on the perineum, horse riding, so many things. Bicycle riding can cause straddle injury. And what do you do? So what do you do? Most of the time, what you just want to do is just you want to divert that urine. You don't want that urine to be flowing through um, that that urethra that is injured. So most of the time, you will have done a superior diversion. So you can put in a suprapubic catheter. You will have done a suprapubic cystostomy. Then you put in a catheter there to drain um, the bladder so that the urine doesn't even flow downwards to the urethra, right? Um, if the urine damage, if the tissue damage is very significant, or you want to delay the surgical repair, particularly for complete transection, you might want to divert the urine initially, and you do the surgical repair later. So, but while you wait, you want to divert the urine, right, so that you can allow that area to heal, to allow the inflammation there to subside, right? So you can do a ureterostomy, sorry about that, a ureterostomy, or you can insert a suprapubic catheter. So what we are just essentially saying is that um, going back to our first stage, so if the tear is, let's say, here, right? This is where the tear is. So you can do a ureterostomy by making a small hole, an incision here, so that the urine that's coming from the bladder will be diverted at this point, right? Or you can just put a suprapubic catheter here to divert the urine, allowing this area to heal up before you now come in after some weeks to do the complete reconstruction, right? Especially if the trauma is very extensive. If the trauma is not extensive, just have a partial tear. By the time you do your you put in your catheter here to drain the urine, it will heal up after some few weeks. You don't need to do any surgical repair, right? The same thing happens for um the posterior urethra. The posterior urethra is majorly due to, like, injury involving the membranous anteprostatic urethra. We have said that, and that's usually very common in people that experience pelvic fractures. Very common pelvic fractures. And the membranous urethra is the most susceptible segment of the entire urethra due to its higher mobility. So it is very, very mobile. It has limited, ligamentous attachment. So it's very, very mobile. It can easily fly from one part to another part. So, and it can shear off easily. So if the tear is partial, you can just put in your urethral catheter, your urinary catheter rather, in the bladder, drain the urine. That area will be devoid of urine for some time, and it can heal up. If it's complete, you might need to put in a suprapubic catheter, you know, divert the urine, and later come back for your surgical repair. So both of them, they need a suprapubic catheter initially, but if it's partial, your suprapubic catheter is enough to allow the stop heal. When it's complete, you put in your suprapubic catheter, you wait for some weeks, then you come back and do your surgical repair. That is all about the management. For rectal and vaginal injuries, of course, these are other structures, concomitant areas of injury. So you have to evaluate if there's any injury to this part by doing your DRE to check for the rectum if there's any bleeding, to check for any nerve compromise, by assessing for the um for the sphincteric tone of the rectum, right? You also check the vagina, you look at the introitus of vagina, if there's any bleeding, any laceration, if there's any distortment, you might need to do your reconstruction. So most of the time, you just manage them non-operatively. You don't do anything, just supportive wound care. But if there's like anatomic distortion, you need to do a reconstruction as soon as possible. So that will be the end of our lecture.